This presentation is on chest pain patients as part of our EMT education program. Assessment and treatment of chest pain patients is based on determining if the patient has shock or hypoxia, with our standard symptom list there: tachycardia, cool pale clammy skin, tachypnea, vital signs change, and then working on increasing that patient's supply of oxygen, either through supplemental oxygen, nasal cannula, non-rebreather mask, or through assisted medications with their nitroglycerin. Nitroglycerin opens up the coronary arteries, the arteries supplying the heart muscle, and therefore bring in more oxygen via an increased blood supply. At the same time that we're increasing patients' oxygen supply, we also want to decrease their demand. Anything we can do to help keep them calm, reduce the stresses around them, and certainly reduce their exercise and their movement. While all this is happening, we're gathering sample history and OPQRST, and we're preparing for transport. Now, OPQRST helps us get more details on that chief complaint, which we will use to try to figure out what the cause is. And sample history, of course, lets us get a more detailed history in general of the patient. There are numerous causes of chest pain. Myocardial ischemia being our primary one that we're concerned about. Is this angina? Is it a myocardial infarction? And then there are other causes as well, many of them pulmonary. It might be a pulmonary embolus, it might be pleurisy, it might be a pneumothorax or pneumonia, or the patient may have musculoskeletal pain, so the pain is actually related to chest wall or chest muscle pain. Or there are anxiety causes. Certainly hyperventilation syndrome causes a number of symptoms, and panic attacks will cause chest pain. So we're going to work through and look at each of these causes and talk about the focused history and physical that we would do to help us determine what that cause really might be. All the while we're doing this, we're gathering sample history, OPQRST, but we have treated for hypoxia, supplemental oxygen, reduced the oxygen demand, and we're preparing the patient for transport. Myocardial ischemia is certainly our main concern with chest pain patients. Cardiac ischemia can lead to cardiac arrest and death. Blood's carried to the heart muscle, the myocardium, through coronary arteries that lie on the surface of the heart. But these arteries can become clogged up, a clot can form, or the arterial wall may actually constrict and create an obstruction to blood flow through either a clog, a clot, or a clamping mechanism. So let's take a rather simple drawing of the heart. There's the septum down the middle. So this would be the left atrium, right ventricle, and this, of course, would be the left ventricle. And then the coronary arteries run on the surface of the heart, supply an area of the heart. And then let's suppose that there's a blockage that occurs right here, some sort of obstruction from a clot that formed there, or a clogged up area that then ruptured and a clot formed, or a vasoconstriction, so there's a clamping down, or some combination of the three. And initially, all the heart muscle that artery feeds will become rather sick. And as time goes on, more and more that muscle gets sick. It's ischemic. It needs oxygen because there's no blood flow. You need to do something to open up that clot or clogged or clamped area, because as time goes on, as you see in the darker color, the muscle gets sicker and sicker, and the sick area expands to become almost an injured area, and then eventually you'll start seeing infarction, death of tissue. That tissue doesn't go away, it just simply doesn't pump as effectively any longer. So it's a time-dependent thing. We need to get that clot removed, get the clog relieved, or relieve the clamp. In the meantime, it's all about oxygen supply and oxygen demand. One important non-cardiac cause of chest pain is called a pulmonary embolus, or a PE. This is where a blood clot forms somewhere in the body, typically in the calf muscle, travels to the lungs where it lodges in a pulmonary blood vessel. This happens when people are sedentary post-surgery or bedridden for whatever reason. There's also a significant increase in risk for those who smoke while taking birth control pills. The pain is typically sharp, so it's usually different than cardiac pain, but you can't always rely on that. It's typically localized. The patient can put one finger on it. It's a sudden onset, usually comes along with shortness of breath, tachypnea, hypoxic, but lung sounds are clear. So this is a very short of breath patient who you expect to have wheezes or crackles or strange lung sounds, and the lung sounds are clear. There's no real definitive field treatment, rapid transport, support with oxygen in the meantime, and there's a significant risk for cardiac arrest in these patients. PEs can be a life-threatening event. Other pulmonary causes of chest pain include pleurisy. Pleurisy is an irritation of the pleura, either the visceral pleura or parietal pleura. One is the lining of the lung, one the lining of the chest wall, and there's a small amount of fluid that lies between the two pleura, but they're stuck together for the most part. And there can be an irritation there that causes very painful breathing. Lung sounds may be clear. You may hear a rub, a friction rub, but again, lung sounds and an assessment of whether the pain is better or worse with a deep breath is an important part of your focus history and physical on chest pain patients. Another possibility is a pneumothorax, where there's actually air in the pleural space, which with a partial or total collapse of the lung, you may be able to assess that with lung sounds, but certainly that should be painful to take a deep breath. And then pneumonia, an infection in the lung tissue, typically accompanied with diminished lung sounds over that infected area, although that may be hard to hear if it's a small area or a smaller person where you may be hearing lung sounds from other places. Should be painful to breathe, may be painful to touch, and a lot of them will have fever and chills. So focus history and physical on your chest pain patients needs to include deep breaths, lung sounds, and fever and chills. Certainly any injury to the muscles and bones in the chest, either the chest wall, rib injuries, intercostal muscle strains, chest muscle strains, all of these are also potential causes of chest pain. And it would be important in your history and physical to, again, look, listen, and feel, palpate the chest, ask about any trauma, see if there's any pain with breathing and with chest wall movement, with range of motion in the arms and shoulders, looking for this is a possible cause. Certainly we should continue to treat as though it is a cardiac situation while we investigate these other sorts of causes. Patients can also have chest pain from anxiety-related causes, hyperventilation syndrome, where the patient is breathing too rapidly and also too deeply, typically due to an emotional stress of some sort. These patients will have a number of symptoms, including chest tightness, tingling lips and fingers, a variety of other symptoms, and all this tends to be a feedback loop to where the more symptoms they have, the more upset they get, the faster they breathe, and the more symptoms they have. Panic attacks are also kind of grouped into this anxiety cause group, and those can cause a variety of symptoms. It's a very real situation, certainly something we should take seriously. Reassurance is the key, a good history and physical, including all the things we've talked about to this point, and typically these folks will have to be assessed by ALS personnel and almost certainly transported. The EKG that's done by the ALS personnel cannot rule out cardiac ischemia. You can rule it in if you see it, but you can't rule it out. And so most of these folks will end up having to be evaluated at the ER for this sort of a thing to rule out whether it's a cardiac cause or not. So to recap, chest pain patients, our main focus is to assess them for shock or hypoxia, treat them by increasing their supply of oxygen, either through supplemental oxygen that we bring or nitroglycerin that they bring, and at the same time decrease their demand for oxygen, lower their stress levels, find all the things that we do that may add to their stress. Let's certainly don't have them up walking around. We gather sample history, OPQRST, while we're doing all this and while we're preparing for transport. In almost every case, these patients will need to receive ALS assessment and transport to an ER.